Good morning, students. We are almost to the end of our lessons on virology. In this class, we shall take up 3 more viruses, of which 2 are vaccine preventable, Rubella and MUMPS, and the third one although it is rampant, and every one of us have already suffered from it, but it causes a very trivial type of infection, that is respiratory syncytial virus infection. To begin with Rubella. Rubella, at one time it was told that Rubella is not found in our country. But later on, this notion is changed by a study in the School of Tropical Medicine. From the newborn babies, they have collected the samples from newborn babies, which showed some malformations, and many of them had congenital cataract, and they could isolate the virus and demonstrate the antibody in mother's serum. And mother to child transmission and fetal malformation is one of the major concern for rubella in our country, as well as in other countries. Otherwise, rubella is a self-limiting disease, case fatality is very rare, and it mimics many other exanthematous disease, that means fever with rashes. Often it is asked in the examination, enumerate the viruses that cause fever with rashes. So rubella, other name is German measles. It is a contagious viral disease, distinctive by its characteristic rash. Rubella is not the same as measles. Often we mistook measles as the rubella because of the two shares some common characters. The exanthematous rash among the viruses on the left hand side, and there are many bacteria on the right hand side of the slide. To enumerate them, amongst the virus, these are measles, rubella, roseola infantum, ecovirus, Coxsackie virus, many times adenoviruses, and infectious mononucleosis viruses. These are the major viruses that is found in our country and causing exanthematous rash. That means the red malarial rash over the body along with fever. Among the other causes apart from viruses that might encounter with fever with rash are scarlet fever, then meningococcemia, then Kawasaki disease, then drug rash, and lastly allergens. These are the common reasons, etiologies other than the viral etiology that cause exanthematous rashes. To talk about the rubella, the slide depicts the taxonomic positions of the virus. You note the genus is rubivirus and subgenus is rubella virus, and it has got 13 genotypes. You need not remember the exact genotypes, but remember that there are 13 genotypes of rubella viruses. This is the life cycle of rubella virus. It is a RNA virus which, after entering into the cell, it took the similar path as the other viruses. Virus replicates, called the cell lysis, and virus releases. The released virus then attack the new susceptible cell lines. Some basic feature of the rubella is it causes mild illness, even in immunocompromised persons too. And many cases the rubella is asymptomatic. About 25% cases it is said to be asymptomatic, very similar to the coronavirus. The maximum number of cases are asymptomatic. Incubation period is about 2 to 3 weeks, and this is characterized by fatigue, headache, fever. There is some constitutional symptoms as we find in other viral infections. There are also some minor respiratory symptoms also for 1 to 7 days before the rash appears. The rash appears on the 7th day after illness has started. Pathogenesis, the rubella virus that develops in the nasopharynx first, so it is inhalation. Infection is acquired by inhalation. It lodges in the nasopharynx first, and thereafter it spreads to the respiratory tract. Hematogenous spread leads to skin infection, then lymph node, local lymph node involvements, then it might spread to the joints, and in case of pregnancy, it may pass through the placenta to the fetus. If it is respiratory infection predominantly, then it is cough, minor sore throat might occur, along with the skin rash. In the skin, we find rashes, and sometimes the rashes conglomerate to form the lesions. In the lymph node, in the draining lymph nodes, especially around the nasopharynx, we find lymphadenopathy. In the joint, there is mild arthralgia or arthritis. If it passes through the placenta and affects the fetus, it causes placentitis and fetal abnormalities or malformation, especially if it occurs in the first trimester of the pregnancy. So, march of events is described here. Rubella virus from respiratory infection secretions to the infected persons comes into the contact with the epithelial surface of the nasopharynx first. Then it localizes the infection in the respiratory epithelium, where it establishes the infection, multiplies, and spreads to the regional lymph node. From regional lymph node, then viremia occurs. First, after the viremia, the infection established in the skin and other sites, as is depicted in the last slide. This is followed in the between 10th to 17th day of infection, maximum viremia and viruria, even in the urine it might be found. And between 10 to 24 days, maximum nasopharyngeal virus shedding occurs about 3 days before to 7 days after the rash of onset. Viremia decreases thereafter, and then the infection dies down with the development of the neutralizing antibody in the patient's serum. Pathogenesis of the congenital rubella infection, the maternal infection in the respiratory route, maternal viremia, and that might lead to abortion of child or the stillbirth, or if the pregnancy is saved, then placental infection might occur causing placentitis, and this is followed by pan-embryonic infection persistently established, and that leads to mitotic inhibition and apoptosis of the cell, destruction of the ocular lens, growth retardation, bone lesion, and generalized derangement of the organogenesis. The ocular lesion is very striking one that leads to congenital cataract, and if it lodges in the brain, then it might cause brain tissues, or might cause mental retardation, and central and cochlear deafness is also occur. So, commonly it is the ocular lesion, mental retardation, central and cochlear deafness. These are the most prominent fetal abnormalities or the abnormalities when the baby is born out of the mother who has developed rubella in the first trimester of pregnancy. That is why the rubella vaccination is desired before 16 years age of a girl child. Rubella in the fetus, the rubella virus infection in the early week of the pregnancy, that leads to enzymatic slowing of the metabolism and catabolism of vitamin A, leading to its accumulation in the liver. So, acute liver damage and cholestasis might occur. Spillage of retinoic acid in bile and the leakage of the retinyl esters into the circulation from the damaged hepatocytes might occur, and as a consequence mitochondrial damage, apoptosis and alteration of the DNA occur, and that leads to congenital rubella syndrome. So, rubella, the mechanism of the congenital rubella syndrome characterized by the phenomenon described in the previous slide. Prominent among is the ocular abnormalities, deafness, mental retardation, encephalitis, bone involvement, etc., as well as the liver involvement. But the key is of this pathogenesis is in the liver, where the metabolism is deranged by the rubella infection, and spillage of the retinoic acid in the bile and leakage of the retinyl esters into circulation, and that damages the hepatitis. And there will be mitochondrial damage in different cells that leads to apoptosis and alteration of the DNA too. Symptoms: mild fever, it's not very high, about 102 degree Fahrenheit or lower, even lower. So, it is a mild fever. There will be headache, stuffy and running nose. So, these are characteristic of the measles too. There is inflamed red eyes, again it is similar to measles. Then enlarged standard lymph nodes at the base of the skull and the back of the neck and behind the ears. And there is a fine pink rash that begins from the face. In case of measles, it is around the hairline first, then face, and quickly spread to the trunk and then to the arms and legs, and before disappearing in the same sequence. There will be aching joints, especially in the young women, and petechiae on the soft palate is a very characteristic phenomenon in case of the, as is shown in the picture on the upper right side, is the characteristic of the rubella rash. The rash in rubella are usually pink flat spots, begins to appear on the face within 1 day, and the rash fades from the face and spreads to the torso, the tongue, then ultimately the extremities. These flat spots, also called the macules, merge together in the trunk but remain separated, discrete on the extremities. Peeling occurs later in the rash areas. The rash might itch. Itching is also characteristic. It is usually gone in about 3 days after appearance, and in 25% of the outbreak may have no rash. I said that it is asymptomatic. Cases might occur and contagious a week before to a week after the rash appears. These are the common characteristic of measles rash. So, after the scaling, it leaves behind black pigmentations too. That is the very characteristics of the rubella. This black pigmentation of the skin might persist even to months or years. Complications: usually no sequelae to the person. In case of infection in the first trimester, 90% chance of development of the abnormality of the newborn. The developmental abnormality to enumerate are growth retardation, cataract, deafness, congenital heart disease, defect in other organs, as well as the mental retardations. So, again I mention what are the congenital abnormalities. If the fetus is affected by the rubella virus, these are growth retardation, cataract, deafness, congenital heart defect, defect in other organs, and mental retardations. Here is a comparison between measles and rubella. As regards severity of the disease, measles is a more severe form. Sometimes life-threatening complications might develop in following measles infection, but in case of rubella, the persons involved show mild or no complications at all, but the fetal complications might develop in case of pregnant woman. The woman does not develop any complication, but this fetus develops complications. Then hairline rash is usually in case of measles, not such, directly face. Fever very high in case of measles, it is low grade fever. In case of rubella, symptoms like coryza, conjunctivitis and cough are prominent in measles. Here headache, joint pain, painful lymphadenitis over the back of the neck and ear are common. And measles caused by morbillivirus and rubella is caused by ruby virus. predominant stage, prodromal stage, yes, prodromal stage does affect in present in case of measles, but no prodromal stage is found in case of rubella virus infection. The rash is morbilliform in case of measles, and there is macular rash in case of rubella. So that is the how clinically we can differentiate between a case of rubella from measles. As regards serology, in the base we find the timeline in weeks. In the y-axis, the serum antibody titer. So serum antibody IgM first appears between 1 to 2 weeks, and it gradually comes down to the basal level unless a second infection does occur. And in case of IgG, antibody may persist for about 1 month, then it gradually comes down to a lower level and persists for many months. But at this stage, a reinfection might lead to a very high rise of IgG antibody at the onset. Laboratory diagnosis. Laboratory diagnosis, rubella in mother is diagnosed by serological test. By ELISA using U1 and U2 antigens, we detect the IgM antibody in mother serum. Besides, for retrospective diagnosis, rubella specific IgG antibody like E1, E2 antigen may detect the IgG, specific IgG by ELISA. If IgM is positive, that indicates recent infection. If IgM is negative but IgG positive, it might be a past infection or it might be due to vaccination. In case of fetus, rubella specific IgM by ELISA might be detected in cord blood. Rubella is a vaccine preventable disease. So we find there is rubella is a vaccine preventable disease. Most vaccine contains RA27-3 virus strains, and this is a live attenuated virus. There are Japanese derived strains include the Matsuda, Takahashi, and Chinese derived strains are also available. The rubella vaccine is given on the 9th month of the pregnancy, 9th month of the fetus baby's age, and then it is might be repeated at the age of 16 years for boosting the immunity. Then respiratory syncytial virus. All of us has probably suffered from respiratory syncytial virus, one or other strains. This is a significant cause of hospitalization of the children in our country. One of the leading cause of the death of infants of less than 1 year of age worldwide. There is exacerbation of pre-existing chronic airway disease due to new infection by respiratory syncytial virus, and a respiratory syncytial virus leaves behind in the respiratory tract some chronic sequelae too. There is a link between this infection and the asthma, and those who suffer severe respiratory syncytial virus infection early in childhood later usually develop asthmatic illness. The mortality rate of respiratory syncytial virus in transplant recipient is significantly high, a risk factor of bronchiolitis obliterans. Otherwise, the patients usually come round. Taxonomy, it is an Orthomyxoviridae DE family and subfamily Pneumoviridae DE because it affects the respiratory tract, and the genus is Pneumovirus, subgenus Respiratory syncytial virus. There are two types of respiratory syncytial viruses available. One is so there are two varieties of respiratory syncytial virus that affects us. These are RSV-A and RSV-B. There is minor epitopic difference or antigenic differences, minor antigenic differences between the A and B detectable by monoclonal antibodies. Basic virological facts about RSV is it is an enveloped virus, and it is a spherical, but filamentous form also exists. Non-segmented negative sense RNA. The RNA is very error prone and has no proofreading function. This is very important. This allows short nuclear fragment induced mutation and affecting the virulence. And transmembrane glycoprotein is also available here that juts out of the envelope, and that determines the receptors and antigenicity of these viruses. Proteins of the respiratory nucleic acid encodes the following proteins: internal structural protein or M protein or matrix proteins, non-structural protein NS1 and NS2 to evade the innate immunity, and a surface glycoprotein, that is SH, and fusion protein F, transcription regulating proteins M221 and M22. So, of these matrix proteins NS1, NS2, surface glycoprotein, and transcription regulating protein M21, M22. These are the different types of proteins that is encoded by the genome of the RSV virus. And this is a description of how this virus goes inside the cell by phagocytosis methods, and there it generates new viruses which comes out by budding. Replication replicates is apical ciliated bronchial epithelial cells. These are the sites where it binds and where it affects the lining epithelial cell, and that leads to sloughing of the ciliated epithelial cells, and there is inflammation, and inflammation causes lower airway obstruction. Exaggeration of the pre-existing airway disease might occur, and there is a link between RSV infection and asthma, and it precipitates acute asthmatic attack. And after the respiratory syncytial virus infection period is over due to development of the local and systemic immunity, it leaves behind a degenerated lining of the mucosa, which paves the way for bacterial colonization there, leading to further pneumonitis. So, this is the slide which depicts the asthma during respiratory syncytial virus infection. It shows that as the virus multiplies inside the epithelial cells, it induces secretion of different varieties of interleukins, of which interleukin 33 is important. Interleukin 33 productions and is related to asthma susceptibility. Sloughing of the dead and infected cell mediated by RSV non-structural protein 2, and besides interleukin 4, 5 and 13 are also important to propagate and release the asthma promoting cytokines. Sloughing of the infected ciliated bronchial epithelium by protein NS2, and that leads to infection of the lower respiratory tract by bacterial colonization. So, it starts with interleukin 33, which stimulate group 2 innate lymphoid cells, that leads to activation of these cells, leading to secretion of interleukin 4, 5 and 13, and these are the inflammation promoting interleukins that cause inflammation and sloughing of the infected ciliated bronchial epithelial cells, which is also facilitated by NS2 proteins, and because of this sloughing of the mucosal cells, this leads to the facilitation of bacterial colonization and co-infection, and together with the respiratory syncytial virus followed by bacterial infection leads to severe type of respiration of the respiratory infection of the lower respiratory tract. So, who are at risk for RSV? it is said that the infants and toddlers are more at risk. Comorbid conditions of infant and toddlers they facilitates RSV infections amongst this group of patients. These comorbid illnesses are low birth weight, immunological deficiencies, Down syndrome, congenital cardiac abnormalities. Other persons who are at risk are elderly, adults with the comorbid illnesses, and persons receiving anti-rejection drugs after transplantations. So, these are the persons who are at risk: infant and toddlers having some comorbid illnesses, elderly people, adult with comorbid illnesses, and persons receiving anti-rejection drugs in case of transplant patients. Lab diagnosis, routinely it is not undertaken because it is a self-limiting disease in most cases. Otherwise, if you want to prove that this is a respiratory syncytial virus infection, then the sample is cupped out sputum, or better bronchoalveolar lavage. Swabs from inside the mouth might be taken, but it should come last. Detection is point of care test POCT, as we find in cases of corona. We detect here the antigens, the surface glycoprotein antigen F and nucleoprotein. This is detected by direct fluorescent antibody technique. Then besides this, rapid immunochromatographic tests might be taken for identification. Otherwise, we can do the second generation of the POC test, point of care test. Sensitivity and specificities are much better. Virus disruption followed by immunofluorescent assays. The second generation test, a sample is first treated with some solutions so that the virus gets dissolved, and that leaves behind all the varieties of antigen present there, and then it is subjected to detection of the antigen by immunochromatographic test. Besides, molecular diagnosis might be done by RT-PCR. Besides, e-sensor of respiratory tract panel and Luminex RVP panel, now it is being popularized by many companies. They send a kind of panels where with the microarrays or DNA hybridization, by which we can detect a number of respiratory viruses that commonly affect in certain geographical regions, of which RSV is common all over the world. So, I stop here. I might take up something more in the next class.